Welcome to the discussion of the Uworld question ID 2167. The patient is a 66 years old male. He came up for a routine follow-up visit, but he's complaining of fatigue. It's mild. I'm relating it to the hyperkalemia seen in the labs in the upcoming slides of this question. Hyperkalemia causes muscle weakness, and I assume this is the cause of his fatigue. Past medical history of this patient includes hypertension, type 2 diabetes mellitus, hyperlipidemia, chronic kidney disease, and ischemic cardiomyopathy. Something to note here is that hypertension and type 2 diabetes mellitus, or diabetes mellitus in general, causes kidney disease. Maybe they are the cause of this patient's chronic kidney disease, because these two are the most common causes of chronic kidney disease. By examination, there are normal vitals and moist mucous membranes, and a hollow systolic murmur at the apex of the heart, and trace edema. I assume that he mentioned moist mucous membranes because there are multiple causes of hyponatremia, and there would be hyponatremia in the labs, as we will see in the next few slides. So, if the question is about hyponatremia, there are multiple causes and can be divided into hypovolemic, hypervolemic, or euvolemic. Mentioning that there is a moist mucous membranes excludes dehydration, so this patient is not hypovolemic. I assume this is why he added it. Hollow systolic murmur at apex, unchanged from previous visit. This is due to his ischemic cardiomyopathy history. There is a trace edema in the lower limbs, and trace edema means it's 1+. It's graded as 1+. 1+ means there is 2 millimeters indentation when we pit or press on the edema. Labs are as follows, but I want to stop here to think about one thing. Why did we order these labs? I assume it's related to the fact that he has chronic kidney disease. That's why we would like to make a blood urea nitrogen and creatinine and electrolyte panel as well. Glucose for his diabetes mellitus. And by examination, we already excluded hypertension, or not hypertension, like the hypertension is managed properly. There is no increase in blood pressure. And I would advise that we would follow triglycerides as well, because he's hyperlipidemic patient. So why wouldn't we follow triglycerides and LDL, HDL, total cholesterol? These things would be helpful. But the thing is, maybe he didn't want to add them, not to extend the question any further. But adding glucose would be beneficial for the purpose of the question, as we will see in the last slide. There is hyponatremia and hyperkalemia, and we will discuss that. This is the core of the question. Blood urea nitrogen and creatinine are increased because he is a chronic kidney disease patient. The ratio between them is normal, and creatinine is slightly increased from the previous labs, which was 2 months ago. The point here is we grade chronic kidney disease into 5 stages. They use estimated GFR for this purpose, and creatinine is one of the things we use to calculate the estimated GFR. So there is a slight increase in creatinine. We use it to calculate estimated GFR by certain equations. There is hypocalcemia. This hypocalcemia is related to renal disease. This is a slight hypocalcemia because the lower limit of the normal value is 8.4. This is 8.2. The glucose level is increased, whether it's fasting or not, or random, this is increased. So you think about controlling diabetes further. We did an ECG and it was normal. Why did we do the ECG? Because there is hyperkalemia. Abnormal potassium levels can change ECG. So we requested an ECG to see if there are abnormalities. But it was normal. The next step is to review the medications. And it's obvious because this is a routine follow-up. We should review medications. In a clinical practice, we would do that. But the thing is, here, he wants you to know that one of the causes of hyperkalemia is medications. Some medications like ACE inhibitors increase, and they listed it in the explanation. And he mentioned in particular the ACE inhibitor drugs causing hyperkalemia. He's taking it for his cardiomyopathy, for his history of cardiac disease. I can add that beta blockers and spironolactone are also added for these patients, might be taken. Digitals as well, you might be taking digitals for heart failure or any reason, symptomatic management. And this is related to the cardiology branch of medicine. Anyways, you should review medications. But calcium gluconate must be given immediately if there are ECG changes. There weren't, as we saw on the previous slide. If the potassium level was above or equal to 6.5, it wasn't. And if there is a tissue breakdown, like in a case of crash injury. Why? Because this rise in potassium is fast. So this is gonna damage the heart, cause arrhythmia or anything. So we have to act quickly by calcium gluconate and insulin and hydration. Another thing to note is hyperkalemia may happen at significant hyperglycemic levels above 300. In previous case, or in this case I mean, it was 196. So hyperglycemia in this case cannot, or it's hard to cause secondary hyperkalemia. That's why he added glucose levels to these labs instead of mentioning the full labs that would be requested, like lipid profile. Albumin to creatinine levels may be helpful to see if there is proteinuria or not. Maybe he done it before in the previous visits, but it would be helpful as well because he's a diabetic patient. We would follow his urine and see if there is proteinuria or anything like that. And that concludes our revision for this question. Thank you and good luck.